title of this lecture is Utility of Gel Sonovaginography in Gynecology. I will take us through the technique of gel sonovaginography after the introduction, and I will round off with a take-home message. The learning objective is to appreciate the usefulness of gel sonovaginography in gynecology. All images for this presentation were of cases managed in 2 hospitals in Borno State. This paper, published by Malasibal in 2016, gave birth to gel sonovaginography, which she titled as a new way of evaluating a variety of local vaginal and cervical lesions. My presentation is largely based on the method described in this paper. Gel sonovaginography delineates vaginal and cervical lesions better than conventional transvaginal scan. It is an easy-to-learn technique. I see this procedure like a telescope for viewing vaginal and cervical lesions. Now let's look at the technique. An assistant holds the gel container upside down while the sonologist introduces a 20 ml syringe into the inverted container. Occasionally, I ask the patient to hold the container for me, and I use 10 ml rather than 20 ml syringe, and the results are comparable. Push the barrel over the plunger. This is extremely important. Not pull the plunger from the barrel, as is the conventional use of withdrawing fluid into syringe. This way, 20 ml of gel is drawn into the syringe. This technique reduces the amount of air bubbles in the syringe. And the least that one will want in gel sonovaginography is for air bubbles to blur the anatomy of the vagina and cervix. Then withdraw the syringe, which is already lubricated with gel during withdrawal of gel into the barrel. With the right hand in the vagina, guide the syringe using the left hand between the index and middle fingers of the right hand, just as we do for artificial rupture of membranes. Then remove the right hand and advance the syringe gently and push the plunger to deposit the gel in the upper vagina, commonly in the posterior fornix. Withdraw the syringe and introduce the transvaginal prop. Ensure to minimize air bubbles between the prop and the region of interest. First, examine the lower parts before moving upwards, because air bubbles will form with time and then blur the image quality. When the procedure is completed, gently withdraw the transducer from the vagina. Clean the patient with baby wipe or tissue paper, or give the patient to do same to remove the gel. This is what I do. When the procedure is taking long, air bubbles will form and then decrease the clarity of the image. Once this happens, there is no point repeating the procedure during the same sitting, because the air bubbles will be more and then the clarity of the picture will diminish. In such cases, give the patient another appointment. Malasibal described 2 contraindications: pregnancy and active vaginal bleeding. But in most cases, the indication actually for gel sonovaginography may be related one way or the other with bleeding per vagina. Now, these are the few items I use for gel sonovaginography. Disposable glove, a condom, 20 ml. As I said, I use 10 ml syringe, a serviette. Manasiba described the use of a new pack, but where I practice, it's difficult getting new packs for gel sonovaginography. So I use refilled transparent bottle. Why transparent? Because if I'm withdrawing the gel into the syringe, I will see exactly what I'm doing, and I will avoid areas that are empty or areas that contain air bubble. If I use a non-transparent gel, I won't be able to see that, and the air bubble will blur my image. So here you can see someone holding the container upside down, and here I'm holding a 20 ml syringe. Number two, introduce the syringe into the container, and here you push the barrel over the plunger, not pull the plunger as is the traditional practice. After withdrawal, then you deposit the gel in the posterior fornix and start the procedure of transvaginal ultrasound. The video of the technique for gel sonovaginography has been described in one of my videos. Now, looking at a few modifications of Sibal's technique. Sibal described the use of 20 ml syringe. I use 10 ml syringe, and the results are comparable. Sibal's technique is to use a fresh bottle of gel. You can afford that while you practice. So I use refilled transparent bottle, and I've given a reason why I prefer transparent to the non-transparent bottle. Sibal asks patients to empty the bladder and strain after. I clean the vagina using tissue or serviette or baby wipes. At times, I also ask the patients to clean themselves. Sibal says it's contraindicated in pregnancy and bleeding, but many of the indications are associated with bleeding, and these contraindications truly need validation. So this is a normal finding using gel sonovaginography. You can see the labels: bladder, here is the bowel, rectum, then gel in the vagina, delineating clearly the vaginal walls. You can see the vaginal walls clearly delineated. This was in a patient who had BSO. So here you can see clearly the delineation of the vaginal walls. Again, this patient presented with abnormal vaginal bleeding and was suspected to have cancer of the cervix. With gel sonovaginography, you can see clearly the smooth anterior and posterior of the cervix, normal vaginal contour. You can see there is no really blood flow here, and cervical cancer is highly vascular cancer. So when there is little or no blood flow, to a large extent, cervical cancer can be ruled out. This was a patient with abnormal vaginal bleeding. Here you can see some slight fluid collection that has delineated to some extent this polyp. And on Doppler, you can see the feeder vessel here. And the gel has helped to show the smooth contour of the polyp, which is a feature of benignity. Here you can see air bubbles obscuring the view of the upper aspects of the posterior vaginal wall and the posterior fornix. This was a multipara who was being evaluated for a cervical polyp, and on ultrasound scan we all can see that it is actually not a cervical polyp, it is emanating from the endometrium because of this feeder vessel. So you can see this feeder vessel. This feeder vessel has a high positive predictive value for polyps. So we should look for polyp somewhere down here because this feeder vessel is actually feeding a polyp. Now the blood flow is not seen here because on Doppler, structures parallel to the beam are well seen. So this is parallel to the beam, is well seen. And when it took a turn here, it's not seen because it's perpendicular to the beam. We use GL sonovaginography and you can see the outline of the polyp. Here you can see the outline of the polyp, and at surgery you can see the polyp, which was confirmed on histology to be actually a fibroid, not an endometrial polyp, as diagnosed by the clinician. This was a case of suspected cancer of the cervix. Ultrasound findings on 2D vaginography and 3D are depicted here. And these features are not in keeping with CA cervix. Here you can see gel in the vagina, anterior vaginal wall, posterior vaginal wall, then lip of the posterior lip of the cervix here. On color Doppler, you can see insignificant color flow. On 3D, not the air bubbles here appearing as lesion on the that image, and this should not be confused for a lesion. Now, when you compare this with this picture of cervical cancer, you can see the difference. Here you have a bulky cervix, you have infiltration into the vagina, and look at the color uptake here. Again, this patient, 54-year-old, postmenopausal, gel in the vagina, irregular cervix, not the blood flow to the cervix. And this was confirmed as a case of CA cervix. Clinically, it was stage 3A, but with ultrasound scan, it was upstage to stage 3B. Same patients with gel sonovaginography. Look at the infiltration of the vaginal walls, filtration of the paracolpus. Note that the vaginal wall on this side is free. This is a case that was managed as a CA cervix, but I think it's more of ovarian cancer, probably with metastasis to the cervix. Here you can see the multilocular solid ovarian lesion with hydronephrosis on the same side, and the heterogeneous cervix here with this color flow. And look at this ascites and peritoneal deposits. These are features more of ovarian than cervical cancer. So we thought it's metastasis to the cervix, but unfortunately, the patient died a few days after the ultrasound scan. This was for the 6-year-old who complained of postcoital bleeding, and she had colposcopically directed biopsy, which revealed adenocarcinoma. Here you can see the gel, the vagina, the posterior vaginal wall. You can see the anterior lip of the cervix here, posterior lip of the cervix. You can see this cauliflower-like growth here. Adenocarcinoma is commonly echogenic, unlike squamous cell carcinoma. Here you can see the extension of the echogenicity in the substance of the cervix. And here you can see within the cervical canal, an uptake of color, not to the substance of the cervix, but within the cervical canal. This suggests that there may be cervical polyp. Here we can see, using a different machine, same patient, gel. You can see the posterior of the cervix, anterior of the cervix, and look at this substance of the cervix here. It's echogenic and irregular, and somewhere here you can see a polyp. This is a Nabatean follicle. Here you can see a polyp, a Nabatean follicle, not the irregular margin here. It is suggestive of endocervical carcinoma. She had radical hysterectomy, and look at the anterior of the cervix, posterior lip of the cervix. Then look at the polyp, which was seen as a pedicle flow, not polyp really, but as a pedicle flow on this image. So look at the cervical polyp. The same image on bisection, you can see the cervix here and the cervical polyp. This area was actually stony, hard. And on this popular image, you can see the blood flow to the cervix. And look at the pedicle flow that we saw on the other image. Pedicle flow. Look at the pedicle flow to the polyp. This was a titria, all single nolip, had TA and BSO on account of ovarian cancer. She had completed the 6 courses of platinum-based chemotherapy, but on follow-up, the CA125 was noticed to be rising. She had a CT scan which showed normal study, and this was the transvaginal ultrasound scan. Here without gel, and here you can see with gel in the vagina, bowel. Here, look at the normal vaginal wall, and no evidence of vault metastasis. Here on the number section, you can see clearly there is no evidence of vault metastasis. On 3D, not the air bubbles on the rendered, in the rendered image. This patient presented with antepartum hemorrhage. I wanted to find out whether it was a local cause. This is gel in the vagina, anterior of the cervix, posterior lip, external os. And so here the vagina appears normal, the cervix appears normal, and here again you can see the posterior vaginal wall, you can see the posterior lip, anterior lip. So there is no evidence of any lesion here. But here you can see not the external os, internal os, but the measurement. Beyond that, you can see a heterogeneous lesion. This is blood clot. And here you can see the blood clot compressing the fetal head here. So, using gel sonovaginography, we've ruled out local cause for the antepartum hemorrhage. Here was a patient with pelvic organ prolapse. Here you can see the bladder, the bowel. Look at the fundus of the uterus displaced downwards here. Here you can see the prolapse of the anterior vaginal wall clearly depicted with gel sonovaginography. This area that has a kind of color could be due to chronic irritation, but it's important to take a biopsy to rule out malignant transformation.
sai ka taran yau kana da hali sai ka taran gobe babu hali to Allah shi ya gane wannan.
This area has not taken up color. You can see the posterior lip of the cervix, anterior lip of the cervix, cervical canal. This is ectropion. If I had not examined this patient clinically, probably I would also suspect a lesion here and take a biopsy. But I've examined this patient, and this was cervical ectropion. Now let's look at some videos, starting with this. This is the first video. This is pelvic symphysis, urethra, bladder, rectum, posterior vaginal wall, anterior vaginal wall, gel in the vagina. So here you can see the cervix clearly outlined. Look at the cervical canal with air bubble from the gel within the cervical canal. Look at the posterior vaginal wall, anterior vaginal wall. So this is normal cervix on gel, sonovaginography. Again, here you can see the urethra, the bladder, the rectum, posterior vaginal wall, anterior vaginal wall, then gel into the vagina in a case that was suspected to have CA cervix, not the normal, smooth and regular cervix, normal vaginal wall. So this is in keeping with normal findings on gel sonovaginography. This was a case of CA cervix, not gel in the vagina. Look at the posterior vaginal wall. Look at the thick anterior vaginal wall because there is tumor infiltration into the anterior parametrium, not the irregular cervix. Again, pelvic symphysis, gel in the vagina, anterior vaginal wall, posterior vaginal wall, bladder. Here, look at the irregular cervix, urine jetting from the urethra. Here, look at the irregular cervix. You can see that the cervical anatomy is ill-defined. You can see the bladder mucosa here is irregular. Look at the dilated ureter. Again, not the irregularity of the cervix. Look at the dilated and peristaltic ureter. There was hydronephrosis on the same site. Again, here you can see gel in the vagina. You can see the posterior vagina. You can see deposits in the anterior vagina. This is the bladder. Look at the large and irregular cervix with some calcifications within casting, acoustic, shadows. Look at the infiltration into the anterior parametrium. Posteriorly, look at the vagina here, it's normal. But here towards the posterior fornix, you can see the deposits. Here was this same patient who I think has secondary to the cervix rather than primary cervical cancer. Here you can see the peritoneal deposits, the ascites, and the metastatic deposits all over. For those who prefer the footprint down, this was a case of large corpus hemorrhagicum. But here, what I'm interested in is in delineating the vagina and the cervix using gel sonovaginography. Here you can see the anterior lip, I beg your pardon, the anterior wall of the vagina, posterior wall of the vagina. Okay, so you can see the large corpus haemorrhagicum here. Clearly, you can see the cervical canal here. You can see the posterior wall of the vagina, the posterior cervical lip, anterior cervical lip, external os. So clearly, there is no vaginal or cervical lesion here, as demonstrated by gel sonovaginography. Again, this same patient who had anterior parametrial infiltration. This is the anterior vaginal wall, posterior vaginal wall, introducing the prop after introducing gel. So you can see the deposits already on the anterior vaginal wall. Look at this large and irregular cervix. Look at the normal posterior vaginal wall and normal posterior fornix here. Not the clump of calcification here with acoustic shadowing. And so look at involvement of the anterior vaginal wall. So a few tips and tricks with gel sonovaginography. At times one will have a lot of air bubbles, especially if the procedure is prolonged or the technique of withdrawing the gel into the syringe is faulty. On 3D, you can see these air bubbles. So this should not be mistaken for a lesion. This is another case. Air bubbles, the rendered image will appear as a lesion, but this should not be confused for any lesion. The image of the patient with adenocarcinoma, not the air bubbles here obscuring the view of the upper aspect of the posterior vagina and the posterior fornix. This happens when the technique of withdrawal of the gel is faulty, or when the duration of the ultrasound scan is long. Take-home message is that gel sonovaginography makes the diagnosis of vaginal and cervical lesions more accurate without significant increase in the costs of ultrasound scan. Thank you very much for listening.